For example, we have adult cell, especially epithelial. We have columnar epithelial cell. After damage, after increase in need, convert to other normal, other phenotype. For example, columnar epithelial cell convert to squamous epithelium. Squamous epithelium convert to columnar epithelium. All of cell adult, columnar is adult, mature phenotype, or squamous is mature phenotype. And in metaplasia, we have conversion. What is conversion? Is reversible. I tell to you, metaplasia has not physiology, etiology. Metaplasia almost always is pathology. In pathology state, no physiology, normal cell replaced by other mature abnormal cell. For example, after cigarette stimulation, cigarette smoking, normal columnar ciliated epithelium in the respiratory tract convert to squamous cell. Metaplasia is not transdifferentiation. In metaplasia, differential cell don't convert to other differentiate cell. We have reprogramming in stem cell. Then we have a stimulus. For example, cigarette smoking. Ciliated columnar cell after cigarette injury, smoking injury, and nicotine injury changes, damage. And after this damage, due to adaptability response, the stem cell in area reprogram and produce a squamous cell are resistant to injurious agent rather than columnar cell are sensitive. The tissue is preserved, but function is decreased, function is abnormal. This figure shows pluripotent stem cell converted after to different stimulus to other cells. It's pluripotent mesenchymal cell after growth factor, and different pathway converted to mutable muscle, endothelial and fibroblast, fat cell, osteoblast, and chondroblast. In metaplasia, we have reprogramming in stem cell, and stem cell, according to different stimulus, converted to different tissue. Common metaplasia are columnar to squamous or squamous to columnar. We have few examples of connective tissue metaplasia. What connective tissue metaplasia is controversial. Columnar to squamous epithelium in respiratory tract. Normal histology in respiratory tract is ciliated columnar epithelium in upper respiratory tract. After smoking, after other injuries, for example, air fluent, we have changes in columnar epithelium. After a time, mature squamous epithelium replace columnar epithelium. So, program in the stem cell is icon, and squamous and columnar cell replaced by ciliated squamous epithelial cell are resistant to injurious agent, but don't have normal functional ciliated columnar cell. This figure shows a ciliated columnar cell in A figure replaced by a squamous cell. Columnar ciliated cell have a function for removal of dust, removal of any dangerous material, and secretion of this cell is useful for upper respiratory tract mucosa. But squamous cells don't have normal function, such as ciliated columnar epithelium. And also, squamous cell susceptible to convert to squamous cell carcinoma is a malignant tumor in heavy smoker patient. So, no smoking is recommended. Also, we have other metaplasia. In the lower third of esophagus, it's called Barrett esophagus. Esophagus normally covered by squamous epithelium. In stomach, we have columnar epithelium, secret acid. After damage and after reflux, when we have damage in the lower esophageal sphincter, we have reflux of acid from stomach to lower third of esophagus. And we have replacement of columnar cell rather than squamous cell. It's called Barrett esophagus. Barrett esophagus is also dangerous because susceptible to convert to adenocarcinoma in the stomach if removed early. Barrett esophagus? Yes?
No, it's gastrointestinal reflux disease.
Gastrointestinal reflux disease. Yes, it's not, it will treat. And if we can prolong Barrett esophagus is under, and after a time, unfortunately, Barrett esophagus is susceptible to convert adenocarcinoma. So, serial endoscopy is recommended for early diagnosis and treatment. And treatment is effective because Barrett esophagus is reversible. After treatment, esophageal reflux. So, in this figure, we endoscopic fissure in Barrett esophagus. And also, morphologic changes. We see normal esophagus, squamous epithelium, and replaced by columnar cell and goblet cell, such as intestine mucosa. Also, we have connective tissue metaplasia. Connective tissue metaplasia essentially is not adaptive response, it's controversy. For example, after injury to soft tissue, we have calcification and ossification. This table shows many metaplastic changes in the tissue. For example, ciliated columnar epithelium was bronchial tree after a stimulus cigar smoking, convert to squamous epithelium. Transitional epithelium of bladder normally, after bladder calculus and stone and trauma, convert to squamous epithelium. Columnar epithelium in glandula, after trauma, convert to squamous epithelium. Fibrocollagenous, after trauma, convert to Borbitz mesenchymal metaplasia. Esophageal squamous epithelium, after gastric acid injury, convert to columnar epithelium and columnar glandular epithelium due to vitamin A deficiency. For example, columnar epithelium in the conjunctival tissue convert to squamous epithelium. So, as you see, the most common metaplasia is conversion of columnar epithelium to squamous epithelium. In reflux esophageal, it is reverse. Okay? And we discussed epithelial metaplasia is a dangerous. It's almost always is pathology and susceptible to convert to cancer. For example, lung cancer after prolonged smoking is result of metaplasia from columnar ultimately squamous cell carcinoma, or esophagus we have adenocarcinoma. Okay. We have a small part for this day about pattern of cell injury and cell response, and after that continue tomorrow. We discuss about pattern of cell injury and cell response. We discuss about adaptation, cell injury, reversible cell injury, irreversible cell injury or cell death, necrosis, apoptosis. We discuss autophagia. And we discuss some uncommon feature of cell death or combination of this pattern. Do you remember this? Combination of necrosis and apoptosis. Necroptosis.
Necroptosis.
Okay? Combination of apoptosis and pyroptosis. Okay? And other pattern of cells. But in this session, we discussed about different response of cell to injurious agent. Mechanisms of cell injury depended to some situation. For example, cellular response to injurious agent depended to duration, type, and severity of injurious agent. For example, a small dose of toxin causes mild injury, reversible injury, or less amount of injurious agent. But same toxin with high dose causes irreversible cell injury and cell death. So severity or amount of injury or type of injury is important. Also result dependent to type, state, adaptability, and genetic makeup of tissue. For example, a striated muscle in the cardiac muscle is a striated muscle. After 20 or 30 minute ischemia, has irreversible cell injury and cell death. But a striated muscle in the leg, after 2 or 3 hours of ischemia, has irreversible injury. So different genetic makeup and different need to oxygen in a similar tissue has different response in the heart rather than leg. Or hepatic cell with high glycogen storage tolerate ischemia or injuries rather than hepatic with low glycogen storage. Also, there is different genetic makeup in the different human. For example, some patients with tetrachloride carbon have severe liver necrosis, and this is occur. But in some people, due to difference cytochrome P450 has only fatty change and reversible injury in the liver. Cell injury also results from functional and biochemical abnormality in one or more than one intracellular organ. For example, we have hypoxia, ischemia, radiation, and other injurious agents in the mitochondria. We have loss of ATP, decrease in ATP production due to decrease in oxidative phosphorylation. Energy-dependent function is decreased, so dependent to ATP. And also, in the mitochondria in ischemia or injurious agent, we have increased production of reactive oxygen species, damage to lipid, protein, nucleic acid, so cell injury and necrosis is occurring. Also, cytoplasma membrane, we have damage to the cellular membrane and intracellular organelle membrane, damage to lysozyme enzyme, damage to plasma membrane, leakage of enzyme, and impaired transport of some material in the cellular membrane associated with necrosis. Radiation, mutation in the nuclear material or DNA associated with cell-sick arrays, activation of BH3 family, and then we have excess of pro-apoptotic proteins such as BAM and BAX, we have apoptosis. Also, we have in the stimulus aggregation of misfolded protein due to reticulum endoplasmic abnormal function, accumulation of misfolded protein and unfolded protein associated with apoptosis. So, we discuss more hypoxia and ischemia because hypoxia and ischemia is very common in people and are more etiologic agent to cell injury. We have deficiency to oxygen. All of oxidative pattern and production of ATP dependent to oxygen. So when we have hypoxia due to ischemia or other etiologic agent, we have decrease in production of ATP, and ATP depression is alkaline. In hypoxia or ischemia, we have hypoxia-induced factor 1. Hypoxia-induced factor 1, HIF1, affect some mediator and intercellular mechanisms. For example, is associated with production of many growth factors, such as VEGF, vascular endothelial growth factor. Vascular endothelial growth factor induce neovascularization, production of new blood vessels for better circulation of blood, and also FGF, and also erythropoietin. Erythropoietin with production of many progenitor cells and convert to mature cell and RBC for better circulation and remove of hypoxia. Also, HIF1 causes some pathway of metabolism of glucose. For example, when we have hypoxia, glucose metabolized for production of ATP from glycolytic pathway, and also HIF1 inhibit P53 and cytochrome C because inhibit cell death. Cytochrome C and P53 are mediator of cell death. So, spaghettoangiogenesis, neoangiogenesis, or neovascularization. In normal situation without hypoxia, we have main blood vessel to circulation. But after ischemia, HIF1 produce stimulating VEGF, neovascularization is icon for better circulation. For example, better circulation in the brain, better circulation in the heart, but it's dangerous for this circulation is very small and very susceptible to stroke and thrombosis and perforation of this blood vessel associated with intracranial brain, intracranial hemorrhage, eye hemorrhage, and causes many complications. So, after ATP production in the cell has two pathways: oxidative phosphorylation in normal situation, and then we have hypoxia, glycolytic pathway activated. Major pathway is oxidative phosphorylation. Oxidative phosphorylation of ADP convert ADP to ATP for energy consumption. But in glycolytic pathway associated with hydrolysis of glycogen, and glucose converted to acid luckily for production of a small amount of ATP when necessary. And now, mitochondria is manufactured for production of ATP. Failure of oxidative phosphorylation after damage to mitochondria associated with decrease in ATP. Also, in some situations, we have increased permeability, mitochondrial transmission, release of cytochrome C and other protein, leakage of mitochondrial protein associated with cell death. So, rule of mitochondrial cell injury and cell death very important. When we have decrease in O2, toxic radiation, we have decrease in ATP, reactive oxygen species is increased, multiple cellular abnormality and necrosis occur, and when we have decrease in survival signal, DNA or protein damage, we have pro-apoptotic protein, increased activity and decreased anti-apoptotic protein, release of cytochrome C, and some protein from mitochondria and apoptosis is occurring. We have many function in the cell dependent to ATP. For example, sodium-potassium pump. We have many transport pump in the intracellular membrane and causes with consumption of ATP, causes exit of water and sodium out of cell and interpotassium to intracellular environment. After damage to ATP, this pump is disturbed and sodium-potassium pump is not working. So we have accumulation of sodium and water to intracellular. And cellular swelling is occurred due to absence of ATP for function of this pump. We have 5 cellular systems are vulnerable to injury. The first is ATP production in mitochondria, cell membrane, genetic apparatus. We discussed 3 organs previously. But protein synthesis is also damaged, and cytoskeleton is damaged. After damage is 5 systems, the cell death is ATP is important for protein synthesis, for lipogenesis, for the acetylation, reacetylation, and phospholipid turnover. And it is estimated healthy human burn 50 to 75 kilograms of ATP every day. During oxidative phosphorylation, we have transport of electron. We have some with electron donor and electron acceptor. And reduction and oxidation reaction is occur in the cell, in the mitochondria, for production of ATP. Also, this figure shows conversion of ADP to ATP after reduction and oxidation from oxygen. When we have damage to the mitochondria due to reduce in oxygen, mitochondrial damage or toxin, we have decrease in production of ATP. But when we have ischemia, the treatment is removal of ischemia. Okay? In some situation, for example, after myocardial infection, after cerebrovascular accident, ischemia and thrombosis in the cardiac vessel or coronary vessel or cerebral vessel. The treatment is removal of this thrombosis. For example, thrombolysis for acute MI, angioplasty, bypass. But in some patients, after a time, rapid reperfusion causes more severe ischemia. After evaluation of this situation, reperfusion and more ischemia rather than previous reperfusion, the study show is associated with free radical because in the damaged organ we have damaged mitochondria. After ischemia removed, free radical production is increased. And also we have many cytoplasmic proteins such as complement are dangerous for the cell. In some situations we have reperfusion ischemia. Reperfusion ischemia is very dangerous and causes more damage rather than previous step. So in ischemia, we explain again, we have decreased oxidative phosphorylation, decreased ATP. Some ATPase dependent forms such as sodium, potassium, ATPase dependent loss of function. We have accumulation and water and sodium intracellular. We have cellular swelling, reticulum endoplasmic swelling. Detached ribosome associated with decrease in protein synthesis. And anaerobic glycolysis associated with production of lactic acidosis, and cellular enzyme activity is decreased. So ultimately, we have damage to lysosome, damage to mitochondria, and cellular leakage and inflammation. Yes, thanks. When we have ischemia, we have decrease in oxidative phosphorylation, ATP in decrease, sodium, potassium, ATPase function is disturbed, and accumulation of water in the cell is occurring. Also, endoplasmic reticulum swelling, ribosomal detachment, production of protein synthesis due to absence of ribosome and detachment of ribosome is decreased, and also glycolytic pathway associated with an intracellular acidosis, the denaturation of enzyme, and decrease in enzymatic activity. Also, we have fragmentation of mitochondria, release of many material from cell to exit, and inflammation and necrosis is occurring. Okay. What is free radical? Free radicals are chemical species have a single unmade electron in an outer layer and orbit. In some injurious agent, aging, radiation, toxin, and other injurious agent in the cell, oxygen in the mitochondria converted to free radical, superoxide, hydrogen peroxidase, and hydroxy radical are very erosive. Normally, free radical production in the respiratory oxidation is occurring in the mitochondria. Daily, we have production of superoxide, peroxide hydrogen, hydroxy radiation by many enzymes such as glutathione, catalase, and superoxide dismutase to water. But if production is severe in mitochondrial damage, we have damage to phospholipid, to folded protein, and to genetic makeup. Okay, but we have many antioxidants in our body, such as many vitamin, ascorbic acid or vitamin C, vitamin A, beta-carotene, and many enzymes we discussed are antioxidative activity. We have three unique enzymes, catalase, superoxide dismutase, and glutathione peroxidase, convert free radical to inactive material and decrease damage to free radical. Superoxide dismutase convert superoxide to peroxide hydrogen, and catalase and glutathione peroxidase convert peroxide hydrogen to water, and with unique activity remove free radical in our body. Okay, this table show free radical, superoxide, peroxide hydrogen, hydroxide radical, and proximity. Mechanisms of production, mechanisms of removal, and pathologic effect on the cells. In necrosis, we have membrane damage is prominent in necrosis, but membrane damage associated with free radical and in some situation directly without free radical. For example, central arterial toxin causes lipid damage, viral protein, lytic complement component, physical and chemical agent causes directly membranous damage, and membranous damage causes cell death and necrosis. This figure also shows dysfunction of the mitochondria due to phosphorylation oxidative decrease and liquid peroxidation, and also rule of calcium, intracellular calcium. Increase in cytosolic calcium associated with phospholipase activation and protease activation. So we have phospholipid degradation, cytoskeletal damage, and membrane damage more severe and causes cell necrosis. We have some biochemical mechanisms in membrane damage: decreased phospholipid synthesis, increased phospholipid breakdown, and reactive oxygen species causes membranous damage in the cell. Also, we have cytoskeletal abnormality and lipid breakdown product causes cellular injury, especially in the cell membrane, and cytoskeletal protein, and phospholipid degradation associated with membranous rupture and leakage. When we have leakage and damage to the membrane, it is associated with exit many cytoplasmic protein to the extracellular and the blood circulation. For example, after myocardial infarction, for diagnosis of myocardial infarction, we measure enzyme in the blood, troponin, cytokeratin in the cardiac muscle. When we have increased troponin or cytokeratin NB in the blood circulation in the serum of patient in laboratory finding, we diagnose myocardial infarction. For example, alanine aminotransferase in the liver, alkaline phosphatase in the bile duct. When we have excess of amount of this enzyme in the blood, is associated with damage and necrotic cell. We briefly now discussed about chemical injury and then continue tomorrow. Chemical injury. Chemical injury have two mechanisms, direct and indirect. When we tell direct, my meaning is without any free radical production or metabolic production, directly causes damage. But in indirect, we have toxic metabolic or free radical. We have many chemotherapeutic agents and antibiotic. Directly causes injury in the cell. Also serum, directed blood mitochondrial cytochrome oxidase activation and blood phosphorylation oxidative without any free radical. But indirect, the Best example of indirect injury is tetrachloride carbon. Tetrachloride carbon, according to different genetic makeup, converted to trichloride carbon free radical. Trichloride carbon free radical is dangerous, but according to activation of cytochrome enzyme, P450 enzyme has different damage in different patients. For example, in some patients, tetrachloride carbon associated with membrane damage to reticulum endoplasmic, ribosome detachment, and all result is fatty changes. But in some patients, according to activation of enzyme, damage to plasma membrane and necrotic cell is altered and associated with acute liver injury and severe necrotic liver is altered and after the death. Formation of free radical associated with DNA damage. Also we have DNA damage and also misfolded protein. We have protein synthesis in the ribosome and normal folding occur in reticulum endoplasmic. Damage to reticulum endoplasmic or after toxin, we have accumulation of misfolded protein. When we have synthesis protein in the ribosome, we have normal folding in the reticulum endoplasmic. If normal folding is not occurred, mitochondria with chaperone protein, heat shock protein, causes normal folding. If we have accumulation of misfolded protein after stress, UV, we have reticulum endoplasmic response. This reticulum endoplasmic response increase synthesis of some protein for normal folding, decrease synthesis of protein because accumulation of this protein is decreased, and activation of ubiquitin proteasome pathway for degradation of misfolded protein. If it's not possible, apoptosis is occurred due to accumulation of misfolded protein. So, when we have mild endoplasmic reticulum stress, misfolded protein with changes in synthesis of chaperone, decreased synthesis in protein, and degradation of protein is removed. But in severe stress, we have activation of BH3 activation and apoptosis and cell death is occurred. We discussed about some pathologic agent and some disease due to misfolded protein. We have three types of disease. Some disease caused by mutant protein and that are degraded, leading to their deficiency of some necessary protein. For example, in cystic fibrosis, we don't have in this patient normal canal protein, and we have cystic fibrosis. In some protein, accumulation of misfolded protein associated with cell loss. For example, in retinitis pigmentosa, rhodopsin is lost, okay? Or Alzheimer, A-beta peptide is lost. And also, some disease with reticulum endoplasmic, loss of function due to deficiency of protein. For example, alpha-ketotrypsin, when we have deficiency associated with some disease, enzymatic digestion, lung fibrosis, and many manifestations. It's need to remember this table, but for example, you remember cystic fibrosis due to misfolded protein, Alzheimer's disease due to misfolded protein, alpha-ketotrypsin due to misfolded protein. It's enough for your study and for understanding.
Just this three?
Okay.
Okay.
Okay. I finished the class.
خسته نباشید.
سلامت باشین.
مرسی.
شما هم خسته نباشین.
مرسی.
I continue tomorrow.
ان شاء الله.